Hey everyone, my name is Justin Joy, and I'm the current PGY2 in cardiology at Duke University Hospital. And today I get the opportunity to share with you my research project, which is titled The Safety and Efficacy of Sotalol in Patients with Left Ventricular Hypertrophy. For my disclosures, nor myself, nor my project director and co-investigators, Dr. Kristen Campbell and Dr. Sean Pokorny, has anything pertinent to disclose. All right, now in order to understand the significance of this research, it's important to understand what sotalol is. And so sotalol is an antiarrhythmic drug that has von Willems class 2 properties and class 3 properties. This class 2 property is its beta blocking activity, but its class 3 property is what's responsible for prolonging the action potential and the refractoriness of the cardiac tissue. And this class 3 property is what allows it to prolong the QT interval and actually increase the risk of torsades de pointe. Now, because of this risk, at Duke, we actually have an initiation policy for patients who are beginning sotalol for any indication. And as a part of this policy, we get a baseline QT or QTC interval, and we also measure the patient's QTC interval 2 to 3 hours after each of the first 5 doses. Now, the 2014 guidelines for the management of atrial fibrillation actually recommend avoiding sotalol for patients who have left ventricular hypertrophy, or LVH for short, which they define in these guidelines as a septal wall thickness greater than 1.5 centimeters. However, there isn't a citation or reference listed for this recommendation, and there's actually a positive clinical data altogether to really support this. And interestingly enough, in the 2017 guidelines for the management of ventricular arrhythmias, there actually isn't the same caution listed for using sotalol in patients with LVH. Therefore, the purpose of this study was to assess the safety and efficacy of sotalol in patients who had echocardiographic evidence of LVH, which we defined as a septal wall thickness greater than 1.5 centimeters. The primary objective of this study was to determine the absolute change from baseline in the QTC or QT interval after the first and fifth doses of sotalol in patients who had LVH, and then compare this to a control group of patients who did not have LVH. Our secondary objectives were the percent change in this QTC interval after the first and fifth doses, as well as looking at the rate of patients who failed the sotalol load for any reason, and lastly, looking at the rehospitalizations due to arrhythmia within 12 months. This was an IRB-approved, single-center retrospective chart review, and we were able to identify patients via the Duke Enterprise Data Unified Content Explorer database, or DEDUCE database for short. We included patients who were at least 18 years old who were initiated on sotalol between September 1st, 2016 and December 31st, 2019. All patients had to have echocardiographic evidence or a cardiac MRI imaging with the septal wall thickness measurement within 12 months of them being initiated on sotalol, as well as having EKGs that were performed with a physician-interpreted QTC before and during the sotalol initiation. And we excluded patients who had an incomplete medical record. For our statistical analysis, we used an unpaired t-test for the change in QTC from baseline and a Fisher's exact test for the rates of sotalol initiation failure and the rates of hospital readmission. And lastly, we utilized descriptive statistics for the patient characteristics. Now, through the DEDUCE database, we were able to initially identify 211 patients within our system who had a sotalol dosing message. And of those 211 patients, 128 of them met inclusion criteria, and the reasons for which are listed there on the right. And of these 128, 18 patients had evidence of LVH, and 110 patients did not and were in our control group. Here we have a chart of the patient characteristics of this study, and while I won't read out all of these characteristics that you see here, I did want to point out a few things. First, for the indication of sotalol in both groups, you can see it was about a 50-50 split for patients who were on Sotalol for atrial fibrillation. When we look at patients who were on Sotalol for ventricular tachycardia, it was actually 44.4% in the LVH group versus a less 26.4% in the control group. And the baseline QTc was actually numerically higher in the LVH group at 449 versus 435 in the control group. And for the average change in QTc after the first and fifth doses, you'll see the absolute change after the first dose in the LVH group was 18.3 and 15.9 in the control group, which was a 4.1% and 3.8% change respectively. And for the absolute change after the fifth dose in the LVH group, this was 13.2 as opposed to 28.2 in the control group, or 2.9% and 6.6% change respectively. And in our preliminary analysis, we did not see or note a statistical difference with any of these. And here is a graphical representation of the results from the previous slide, where you can see the change in QTc throughout the initiation. Now, I do want to point out, only 62% of patients had an EKG after the fifth dose for patients who did not have their dose changed throughout the initiation phase. And for our secondary endpoint, first for the Sotalol initiation failure, this was 11.2% in the LVH group versus 16.3% in the control group. And for rehospitalizations due to an arrhythmia within 12 months, this was 16.6% in the LVH group versus 27.3% in the control group, both of which we did not find to be statistically significant. Some limitations of the study was first just the nature that this is a retrospective observational single-center experience, and few patients with LVH actually received Sotalol. And lastly, not all patients actually had a 12-month follow-up for rehospitalizations, such as the patients who were initiated on Sotalol of December of 2019. But in conclusion, I did want to point out first that 14% of the patients in our study that were initiated on Sotalol actually had evidence of LVH. Patients that were initiated on Sotalol with LVH did not have significant changes in their QTc interval throughout the initiation. And the rates of failed Sotalol initiations appear to be similar between both groups, and that initiation of Sotalol in patients with LVH appears safe, but it definitely does warrant future research. And lastly, that our additional conclusions are pending our final statistical analysis. I would like to acknowledge and thank my residency program director and my co-investigator, Dr. Kristen Bova-Campbell, as well as Dr. Sean Pokorny, and the Duke University Hospital Pharmacy Research Committee. My self-assessment question is true or false question. Current guideline recommendations advising against Sotalol for the management of atrial fibrillation in patients with LVH are primarily based on randomized controlled trials. And this answer is false. I appreciate everyone for listening to this presentation. If you have any questions or comments, please feel free to contact me with the email address listed there below, justin.joy@duke.edu.